Okay, great. So let me start, and I would request Dr. Abhishek and Dr. Padma to switch on their video. I think if it is there, okay. So good afternoon, everyone, and I want to begin the session by introducing myself. I am Ravi Prakash, working as a Senior Deputy Director for Monitoring and Evaluation for the Uttar Pradesh Technical Support Unit. As a part of the Family Planning, Monitoring, Learning and Evaluation Consortium, I'm here to welcome you all. And for this interesting workshop, I would say not workshop, but webinar, which is on the role of community health worker in contraceptive uptake and demand for family planning. So again, this is one of the interesting webinar where we had discussed previously about many issues related to family planning, and the role of community health worker is one of them, which is the most important or one of the important. So what we know, from the program, like the influence from the community health workers on the uptake of family planning is key, for any program. And similarly, the family planning is one of them. And what we have seen from the data over the last 5 years, that the health workers outreach for the family planning services has increased tremendously. And still that, the concern earlier, which was that whether younger people or the lower priority are getting services or not. So that has been to largest extent addressed by the community health workers. However, what we know is that in some pockets where the outreach is low, its effect on the modern contraceptive method is significant, and thereby, it is important to learn that who are being met, who are being not met, and how its effect is on the uptake of the family planning method. So this particular webinar is focusing to discuss the impact of the frontline workers on building the knowledge of contraceptive method and the users for increasing, the method use. So let us make this webinar more interactive, and we would appreciate if you can put your questions in the chat box so that we can address them at the end of the day, and then maybe learn more from there. But before we begin, I would like to introduce about the consortium and also our panelists and the discussion. So the Family Planning Monitoring, Learning and Evaluation Consortium is a consortium with multiple partners and constituted about 8 years ago for basically to provide the grounded experience and evidences on the areas of family planning. It is being supported by the Bihar and Uttar Pradesh Technical Support Unit, which is being in Bihar led by the Care India Solutions and Sustainable Development. In UP, it is by India Health Action Trust. And it is the program monitoring unit is led by Population Council. And along with these three, the other partners are like ICRW and Center for Gender and Equity Health, San Diego. So today we have Abhishek, Dr. Abhishek as a speaker, and he's a senior program manager at Population Council Consulting. He's a demographer and researcher and having a vast 8 years of experience in conducting various type of research in the domains of maternal health, newborn child health, also on the abortions and particularly the issues around the adolescent sexual and reproductive health. So he is currently working on the various research areas and focusing basically on the role of private sector, which is again interesting in the family planning, and also trying to generate the newer evidence, which is kind of helpful for the not only the specific states, but also India as a whole. And he's also expanding his support to some of the Northeast regions. So he has many publications to his credit, and we again look forward hearing to him about more his findings. Our discussant is Dr. Padma. She is Director, Care India. She has 25 years of research experience in the health and development program. Also, she has demonstrated a long history of working with NGO, bilateral and multilateral agencies, which is again very kind of heartening to see. And then she has also a skill in epidemiology, sexual and reproductive health, rights, policy, advocacy, etc., etc. She's a World Bank scholar who studied in international development at the Heller School of Sociology, Social Policy and Management, and also studied the reproductive and child health in developing countries from Harvard. So with this background, I would request Dr. Abhishek to go ahead with the presentation, maybe take 15 to 20 minutes for the presentation, followed by we will have the comments from Dr. Padma, and then we will open out for the next 20 minutes with the questions and answers. So over to you, Abhishek.
Thank you so much, Dr. Ravi, for setting the context and for the generous introduction. So good evening, all of you, and I welcome you once again in the today's webinar, which is the sixth in the series of the webinars on family planning being organized by the FPMLE consortium since April of this year. So in the next 20 minutes or so, I will be talking about role of community health workers on contraceptive use and demand generation for family planning services. And when I say demand for family planning, I specifically mean it by intention to use contraceptive among non-user women. Before I start, it is important to mention that the analysis which I'm going to share with you is part of our FPMLE consortium work, which we carried out together. So I am thankful to all the FPMLE consortium partners and our colleagues, and specifically my colleagues Arupen, Francis, Sana, and Ashita for their support in preparation of this presentation. Okay, so these are some of the acronyms which we will be frequently using during the presentation. For example, when we say CHW, it stands for Community Health Workers, and when we say NFHS, it stands for National Family Health Survey. Similarly, when we say MWRA, it stands for Married Women of Reproductive Age, and so on. We have organized today's presentation in following ways. So first, we will talk about national level scenario of the association between CHW outreach and family planning indicators. And these analyses are based on the NFHS 4 and the NFHS 5 data. And unit of the analysis is districts, because in the NFHS survey, the CHW outreach information is collected from non-user women. So we cannot directly link the outreach and contraceptive use by considering the individual. After showing the national level scenario, we will talk about context-specific analysis from Bihar and Uttar Pradesh, which are based on the family planning survey among married women of reproductive age group, which we will be saying as MWRA. And this MWRA survey was conducted during 2020 in Uttar Pradesh by the UP Technical Support Unit, and in Bihar it was conducted in 2021 by the Bihar DSU. And in the MWRA survey, the CHW community health worker outreach information was collected from all women with a reference period of contact in the last 12 months prior to the survey. So from the MWRA, we can directly see the association between the community health worker outreach on contraceptive use as well as intention to use. After that, we will talk about such association in cities of selected state, and that will be based on the analysis of data collected by the PSI India, but the analysis was jointly undertaken by PSI India and Population Council. And going to more specific, we will show the evidence on impact of community health worker outreach on contraceptive adoption in selected learning district of Bihar, which will be based on the longitudinal survey on family planning conducted in two districts of Bihar, namely Darbhanga and Paschim Champaran. And more specifically, this part of the analysis will be based on the reproductive calendar data. Finally, we will end the presentation by talking about key challenges related to community health worker outreach for family planning and the way forward. So let me start with showing the scenario at national level. So we all know about the responsibilities of community health worker in ongoing family planning programs in our country as well as across these two states and other states of India. And just to summarize the role of the community health worker on family planning broadly, they are engaged in identifying the couples who can be potential users of contraceptive. They document the list of such couples. They also identify the newly married women. Further, they provide information about methods, source of the methods, they counsel about side effect of the specific methods and its management, and they also motivate women of the community to adopt a family planning method. Their third and important role is to provide contraceptive services to women. So depending on who is the CHO, like ASA, so if they provide condom, pills, and emergency contraceptive pills, and if it is ANM, then they provide injectables as well as intrauterine contraceptive device. And lastly, they link women to the health facilities who are in need for family planning services and follow up with those women who adopt contraceptive, particularly those who adopted a clinical method of family planning services. So the findings showing this analysis was conducted long back in April 2017 when the district level fact sheet data of the NFHS4 was available in the public domain. Many of you might have seen this analysis before in several presentations. And the purpose of this modeling exercise was to identify that what are the key drivers for increasing the uptake of modern method use. The graph given below indicates value of selected indicators based on the NFHS4 data. Say, for example, if we focus on the yellow color bar, that is showing the situation or coverage of postnatal care visit at the NFHS4 time, which was 62%. And just a graph beside the PNC that is showing the coverage of health worker outreach for family planning among non-user, which was 18% at the time of NFHS4 survey. And the stacks given above these graphs indicate that what would be the level of MCPR if we increase value of the indicators given in the graph below. And the value of the stacks start from 50%. So the green stack is showing the if we increase the PNC at 50%, and the brown is showing if we increase the PNC coverage at 100%. So for example, in case of PNC coverage, if we increase the coverage of PNC by 100%, the MCPR will be 60%. So the color of the stack is showing the coverage of that particular indicator, whereas the number given beside the stack is showing the level of MCPR. Similarly, if we focus on CHW outreach, so if it goes to 50%, the MCPR will increase to 68%. And if the outlet increases to 100%, the MCPR will increase by 100%. So other than all the indicators which are presented in the below graph, we can see that the effect of CHW is maximum. So if we increase certain level of coverage of health worker outreach, it has maximum effect on increase in MCPR. So this analysis is showing that CHW outreach is the most effective driver for increasing the MCPR. And we have tested this modeling exercise with the district level data of the NFHS5, and the results are presented in the next slide. So this analysis presented here tests the hypothesis we discussed previously by showing that what were the changes in MCPR between the NFHS4 and NFHS5 by different level of changes in community health worker outreach across the districts during the same period. And if we focus on the table, so the second column of the table is showing the percentage point increase in CHW outreach between the NFHS5 and the NFHS4. So this is the range. So like CHW outreach increase less than equal to 30%, between 31 to 40%, between 41 to 50%, and more than 50%. And the third column is showing the number of districts in the respective range of change based on the NFHS5. And so this is showing the number of districts which lie in the category where the health worker outreach increase less than equal to 30%, that is 475, and so on. And the fourth column of this table is showing the average value of community health worker outreach in these districts based on the NFHS4 and NFHS5 data. And the last column is showing the average MCPR in those districts for NFHS4 and the NFHS5 data. And if we focus on the very last row of this table, we can see that in districts where the community health worker outreach is increased to around 60%, that is shown in the brown color font, that is 57.3%. In those districts, the MCPR increased up to 70%. So previously we saw if we increase the coverage of health worker outreach up to 60%, the MCPR in those area will go 70% on above. And the same thing we are confirming from the NFHS 5 data, which we have tested previously. So CHW, community health worker outreach, is not only increasing the contraceptive use, but also significantly increases intention to use contraceptive among non-user women. And this evidence is based on our published paper, which analyzed the NFHS 3 and NFHS 4 data. So I'm not going to read the number presented in the graph as well in the table, but let me summarize the crux findings of this slide. So from this graph, we can see that there was an increase in community health worker outreach among women from the NFHS 3 to NFHS 4 survey rounds. And summary of the table shows that if there is a community health worker outreach among women, it significantly increased the intention to use contraceptive among non-user women. So far, this is the national level scenario, which is available from the NFHS data. And in next few slides, we will talk about similar evidence in context of Bihar and Uttar Pradesh, which is the focus states of our FPMLE consortium work. And the analysis for Bihar and Uttar Pradesh are mostly based on the MWRA data conducted by TSU of the respective states. But before we talk about the findings of the MWRA data, we would like to show the change in coverage of community health worker outreach for family planning in Bihar and Uttar Pradesh using the NFHS 4 and the NFHS 5 data. As MWRA data of Uttar Pradesh do not provide district level information on community health worker outreach for family planning, rather it provides information at regional or divisional level. So from this slide, we can see that in Bihar, the community health worker outreach among non-user has increased from 12% to 20%, and in Uttar Pradesh, it has increased from 13 to 25%. District level maps also indicate that increase in the community health worker across the districts of both the states over time. But still, there are many districts where the coverage is low. So in nutshell, we can say we find from the NFHS 4 and 5 data that the community health worker outreach has increased, but the current level is low in both the states. It's just below 30%. And across many districts of these two states, the level is even much lower. This analysis is based on the MWRA data, and it indicates low level of community health worker community health worker outreach among young as well as all women of reproductive age group, that is 15 to 49 years. Say, for example, from the graph presented in the left-hand side, we can see that only 21% of young women and 15% of all women in Bihar interacted with community health worker in last 12 months prior to the survey. And the discussion on family planning during the interaction was even lesser. It was just around 8%. In UP, though the level of community health worker outreach was high, but still far from universal. It's just around 51% among the young women, 38% among the all women. And the graph presented in the right-hand side, that is showing the combination of interaction with community health workers as well as discussion on family planning. So using these two indicators, we prepared a third indicators and categorized into three categories, like those who did not meet health worker, and those who meet but did not discuss about family planning, and those who meet and discuss family planning, showing in the green graph. And what we can show that there is a missed opportunity. So there is a interaction with community health worker, but like 19% was in among women 15 to 29 years of Bihar. But in all meeting, the discussion on family planning is not happening. And that is true across all group of women and in both the states. So there's kind of missed opportunity for discussion on family planning, even when there is an interaction with community health worker in past 12 months prior to the survey. This slide is showing the effect of community health worker interaction and on use of modern method in general and use of modern reversible method in particular. Say, for example, in case of Bihar, we can see that if there is an interaction with community health worker or discussion on FP with them, the use of modern contraceptive and modern reversible methods were high. For instance, MCPR was 17% when there is no interaction at all with community health worker, but it was 25% when there is interaction but no discussion on family planning, and it was 43% when there is interaction as well as discussion on family planning. Similar results we can see for use of modern reversible method. In case of UP2, similar pattern is observed, particularly with discussion on family planning with community health worker and interaction as well as discussion, but not for in general discussion or interaction with community health worker. This analysis is showing the effect of community health worker interaction as well as discussion with them on intention to use contraceptive among non-user women. And we can see with the graphs that in Bihar, intention to use 18% if there is discussion on family planning with community health workers compared to only 8% when there is no such discussion on family planning. We can see similar result for UP in the graph given below. And this analysis holds true even if we adjust for socio-demographic characteristics. Like when we conducted multi-bit analysis, we find that the odds ratio of intention to use is greater than, and it is statistically significant among those who interacted with community health worker or discussed family planning with them, as shown in horizontal graphs for Bihar and Uttar Pradesh. So in next few slides, we will talk about evidence from cities of Uttar Pradesh, Madhya Pradesh, and Odisha, which is based on the data collected by PSI and jointly analyzed by PSI India as well as Population Council, as I talked in the very previous slide. So this analysis is showing the effect of exposure on family planning with ASA on modern reversible method use among women or aged 15 to 49 years in selected cities by slum and non-slum population. And this graph is clearly showing that in urban areas, use of modern method is higher among those women who were exposed to family planning with ASA compared to those who were not exposed, and the gap was highest among slum women. Like in slum women, those who were not exposed, the use of modern reversible method at 23%, where it is among those women who were exposed, the use of 35%. And this finding holds true even after conducting the multi-variate analysis, which are adjusted for selected background socio-demographic characteristics, showing that the odds ratio of using a modern reversible method is significantly higher, particularly in slum area when women are exposed on FP with ASA. Similar findings we can see for intention to use contraceptive among non-user in cities, which were higher when the women are exposed on family planning with ASAs compared to women who are not exposed. This specific analysis among first-time parents given in the table also showed that if there is exposure with ASA on family planning in pilot city, it has maximum effect on modern method use, as the MCPR is 40% or 41%, which is highest among these four interaction group. And the multi-variate analysis also confirmed this finding. So this analysis is part of the output tracking survey data, which was conducted specifically in cities of Uttar Pradesh, where a parallel survey is conducted in cities among adolescent and youth women. So the available evidence also showed, so like we talked about national level scenario and then state level scenario, but the even evidence from urban area also showed that exposure with ASA on family planning has significant positive effect on contraceptive use, particularly among slum women and first-time parents, which are young couple. In next couple of slides, we will talk about evidence from the longitudinal survey, which was conducted in learning districts of Darbhanga and Paschim Champaran. And this survey was conducted by Population Council. The baseline of the longitudinal survey was conducted during July and September 2021, and the second round was conducted during August and September 2022. So there's almost an interval of 12 months between the two survey rounds of this longitudinal data. So the table presented in this slide is showing the changes in contraceptive use status among women from baseline to second round of the data collection. And just to mention, for this analysis, among the baseline group, we excluded those women who were using female or male sterilization, or those who were infected. So what we can see from this table, like among the women who were not using reversible method at baseline, 92% among them remained non-user at the round 2 survey, and only 8% adopted any modern method at round 2. If we focus on the last row of this table, we can see that those who are using any modern reversible method at baseline, 58% of them discontinued using a method, and remaining around 43% or 42% continued using a method at the second round of the survey. And the proportion of acceptors, this is based on the calendar data analysis. So proportion of acceptors are high when ASA discussed to women about uh, this analysis is based on the calendar data and showing the effect of discussion of family planning with community health worker on contraceptive adoption, continuation, and discontinuation. And what we can conclude from the graph is acceptance of a method is increased from baseline to round 2 among those who had discussion with community health worker in last 12 months prior to the survey. And the proportion of acceptors are high when ASA discussed to women about basket of choice. So we had information like, okay, so there's a discussion with ASA or FLW in last 12 months prior to the survey, but what were the topic discussed during the interaction? And we found that the discussion on basket of choice is appearing as a significant predictors of accepting a method, and that has increased from baseline to the round 2 survey. So this analysis is showing that if ASA talks about basket of choice, then it has high impact on contraceptive adoption. So the analysis done so far show impressive findings highlighting the positive influence of community health worker outreach on contraceptive use and intention to use contraceptive among non-user women in general and among slum women and among first-time parents in particular. But going back to NFHS data, we found that while the coverage of community health worker has increased from the NFHS 4 to NFHS 5, as shown in the maps, as well as also in this scatter plot. A scatter plot is showing the percentage point change in community health worker outreach across the districts by a state from the NFHS 5 to NFHS 4 to NFHS 5. But despite this increase, there are several challenges which still persist. For example, current level of outreach is very low, as just only 1 in every 4 non-user women reported that they had interaction with community health worker on family planning. And moreover, there is a huge variation at district level in the coverage of the outreach with community health worker on family planning. Secondly, the data is also showing that there are several districts where there is a decrease in coverage of health worker, community health worker outreach from the NFHS 4 to NFHS 5 data. And third, what affects this low coverage of community health worker or decrease in the coverage of community health workers over time, that is unknown kind of thing. So what messages we can take from today's presentation? There are 5 or 6 things. Let me highlight those. So first thing is that we found that the interaction with community health worker has a significant positive impact on uptake of modern method use as well as on increase in intention to use contraceptive. So there is a need to increase community health worker outreach, particularly in those geographies where MCPR is low, as well as demand for family planning is high. Also, there is need to tap the missed opportunity, as we saw from the findings from the analysis of MWRA survey of Uttar Pradesh and Bihar, that there is, while the overall interaction is low, but even there is an interaction, not in all interaction, the family planning are discussed. So there is a need to tap those missed opportunity. Furthermore, there is a need to train community health worker to provide information on quality of care. Like talking about method availability, method type is fine, but we should also provide women through community health care, like providing the methods available for switching or side effects management kind of thing. There need to be reoriented about that. Then lastly, last few points, like engaging male health workers on to counsel or discuss family planning with men, particularly in context of people in Bihar, where there's lots of stigma and taboo. Women may hesitate to talk on family planning with male person or with husband. So there's a need to engage male health worker for that. And last 2 points, like there's a need to analyze that how the family planning outcomes are associated with number of interaction with community health workers. So far, we have seen overall effect of community health worker outreach on contraceptive use. But if there is a data, or if we can collect data to see how many visit is influencing how influencing the use of contraceptive or intention to use contraceptive. So it's kind of those response analysis is required. So with this, I would like to stop here and thank you everyone once again for your attention. Thank you so much.
Thank you, Abhishek. And you have exactly finished in 20 minutes. So great for being on time. I would now invite Dr. Padma to have her thoughts on this. But meanwhile, also would encourage other participants to put their questions on the chat box. Thank you.
Yeah.
Over to Dr. Padma.
Yeah. Thank you, Abhishek, for the insightful presentation. And thanks, Ravi. So from the presentation, I would like to focus my discussion on CHWs reaching out to young women, one point, and focusing on contraceptive use and also increased acceptance. I think my discussion would be centered around these 3 points from the presentation, and also from the program experience, I would also like to highlight how best we can optimize this resource of CHWs in contraceptive uptake and also demand for family planning. So if we look into
Dr. Padma, if you can switch on your camera to make it more interactive, and Abhishek, if you can put down this presentation so that we can see the screen and more interactive.
Yeah, sure.
Okay.
Yeah.
Thank
So
you.
I was noting down a few points while Abhishek was presenting. So I would like to start this thing, like when we look into the policy, I think it's one of the best policies that we have in our country. And also it's the most effective strategies to address, the shortages of HR, and also to improve access to and also provide quality health services, right? And if we look into how they operate, the community health workers, all said and done, they operate in a setting where the traditional practices and the context is too traditional and the traditional practices emerge, in which communities may feel embarrassed, or maybe shy or hesitant to talk or discuss about contraceptive use. Especially, it makes the CHW's task very difficult to reach out to unmarried males, females, and young married women, right? So that's why, but they have a huge opportunity to increase use of contraception where the demand is high and access is low, and there are geographic and socio-cultural barriers exist. Though, I mean, the data shows that to some extent the CHWs might have addressed these barriers, potential barriers, but still a long way to go in addressing these barriers and also to reach out to the communities where the demand is high. So that's why it is important, if you look into the policy, like the community health workers, they don't provide standalone services, right? They provide services in the community, and also they are connected with the health system, right? That makes it a very cost-effective strategy, I guess. And also, when they interact directly with the communities, definitely there is an increase in uptake of services, and there is also a possibility that there is a less possibility of discontinuation of using contraceptives. So it's not either community health workers providing services, standalone services in the community, or referring the clients exclusively to the health facility to avail services. It's a combination of both that actually makes this strategy is more effective, cost very, cost effective and also uh, very dynamic also, I must say. But unfortunately, there are issues with implementation. That's where I think we need to focus more and highlight the critical role of community health workers, because they actually form a bridge between individuals and communities and the health system, right? So that critical link we all need to recognize and see how best we can actually support these CHWs to provide optimal services to the community. That's one point. And the second point is like, they provide services in the community, right? So where the communities may not be able to travel to facilities, maybe because they are distantly located or otherwise inaccessible. But it's an advantage that, if they provide contraceptives or any other services in the community, that acts as an advantage to the communities. That we all need to highlight when we discuss about the role of community health workers, right? And then the communities also, like, they believe and they trust community health workers because they were selected from their own community, right? So there is a reason behind selecting these community health workers from the same communities, because they belong to similar socio-economic backgrounds, which makes them easy to interact with the fellow communities, fellow members or people within the community. However, maybe the general interaction might be easy for them, but when it comes to discuss about the programs and especially to discuss about the family planning, definitely there must be setbacks for the community and also the community health workers. So how do we break this barrier? Is an important thing to understand. So to begin with, I think we need to train them in a very comprehensive manner. Like comprehensive manner in the sense, I would like to say that the training should be incremental and the training should be hands-on, then to understand and also practical in a sense. And then they should develop skills, right? And then there is a mechanism to reinforce their skills also. So unless this happens, right, it is very difficult for them to have an interaction with the communities. So from the program and from my own experience and the field visits, I realized that they find it easy to have a discussion about maternal and child health, right, pregnancy and ANC visits and child immunization. All these things they comfortably discuss with the communities and mobilize communities to access services in VHS and D or refer them to the facilities. But when it comes to family planning, the huge chunk of young married couple or young women are missed out because they don't have access, or their own hesitation also, like families may not accept them to visit those houses and inform the couple about family planning, right? But they need to understand that family planning is not about increasing the contraceptive use, right? The couple needs to understand what is family planning, how do they plan their family, right? It is not about having children, or it's also about how to plan financially, or if you have any future aspirations, how do you plan to meet those aspirations? Then you can think of having children, how many children you want, when they want. All those things need to be discussed. But I don't see this kind of interaction happening at the community level between community health workers and the community. So the major focus would be on contraceptive methods or mobilization to sterilization services. Right? I think this is a huge gap that needs to be filled, and then we all need to support them through training, and also we need to equip them with skills. For example, the community health workers, when they visit the communities and have an interaction with family planning, and the communities are ready to accept, but then if they don't have enough supplies, then it backfires on them, right? So we also need to ensure that the community health workers have enough supplies to meet the demand within the community. Then they also need to identify for whom they can serve within the community and who needs to be referred to the facilities for counseling or facility-based services. That kind of categorization needs to be understood by community health workers. That's what I feel. And then for supplies, government has introduced FPLMIS, right? Then we have trained ANMs and ASHAs. So, but the managers think that, ASHAs are not very well educated and they don't understand using the mobile technology and FPLMIS, using the FPLMIS app. But how much time the managers are investing in training or providing hands-on training to these ASHA workers. It's not that they don't interact regularly. Every week these managers are interacting with the CHWs. So every week, on an average, if they spend 10 to 15 minutes time and how to operate this FPLMIS app, I think it has huge benefits for the CHWs and also the facilities, because the stockouts can be easily figured out, right? And then the demand can be met because there is a continuation of supplies and there is a sustaining efforts to provide supplies. Automatically, the communities are convinced that the contraceptive use can be increased. That's one thing. And the other part, Abhishek, you mentioned about accepting, right? It also depends on CHW's knowledge and attitude, and also their own understanding of individuals' beliefs and attitudes, right? It's their own attitudes, beliefs, and also the community's attitudes. So they need to understand each client's beliefs and how to, have an interaction with the clients so that, the clients will listen to them and understand the purpose of family planning and then decide whether what method to use and how to adapt family planning approach. And in order to motivate the CHWs to have more interactions, right? I feel that the incentives also play a greater role, right? When incentives, we speak mostly about the financial incentives, which are high. So in a recent field visit, we have interacted with many ASHAs, and then this financial incentives has been greatly streamlined in Bihar, and they receive at least 4,000 to 5,000 in a month in their hands, and they feel so happy. But then, how do we actually, use this opportunity for them to provide good quality service, right? So there are non-financial incentives also we should think of. For example, certification, right? Certification of any course or any training for that matter, because this certification actually helps them to professionalize their services and also focus on the quality and also their performance, right? And in the training also, I mean, I'm not talking about the classroom training. We need to adopt various adult learning principles and participatory approaches. And apart from programmatic inputs, I think the trainings should also focus on the providing softer skills to CHW, such as communication skills and time management, planning their work. They may sound big, but actually not. They are very simple inputs to be given to the CHWs so that it acts as a motivation to them. And along with this, I think they should be acknowledged publicly, recognized for their contribution, right, for the public health. And also, I think there should be a sense of worthiness for their services, and they should be respected for their services. I mean, these things I think we seem to have forgotten, right? So, and then we take them for granted, like CHWs, they don't interact with the communities, right? If they have interact, then there is an increase in contraception use and there is a demand. I mean, how it will happen? It will not happen automatically, right? All said and done, they are also human beings, and if they are recognized for their hard work, I think that could act as a motivation for them. I think we need to, it's time that we need where we actually focused on this softer side of incentives, non-financial incentives, kind of thing. And finally, I also want to say we need to help them to evolve in such a way to provide services that are suitable to the changing needs of the communities, right? So if they have to evolve in such manner, one-time training is not enough for them, right? There should be refresher trainings or hands-on trainings, something like, constant stimulus should be there for them to equip new skills, to equip new technology, to equip with new information, new knowledge, right? That's how, they function very well, and also understand the community's needs. And then we can expect good quality services to be delivered to the communities. And also on the other side, their own performance will also improve. So before concluding my discussion, I just wanted to let you know the study that I came across. So this is an analysis done for 172 countries about the maternal deaths averted by contraceptive use, right? So by preventing unintended pregnancies, family planning has reduced maternal mortality by 44%, I guess. And it could reduce further another 29% if all women whose intention to use family planning, though those women also start using contraception, like another 29% could be averted. Similarly, by preventing closely spaced births, FP could save the lives of more than 2 million children in a year, right? So they need to understand this continuum. Like family planning is not about contraception use, but it has a critical role and importance in achieving maternal and child health also. So this connection and this continuum, unless they understand, and we also need to equip them with this new knowledge and skills. If we want them to perform well and also provide good quality services, I think we need to constantly engage with them. And also with the community level also, you have VHSND and community to support CHWs and also engage with the communities. We have VHSNC also. I'm not particularly highlighting the role of PRAs or SHGs because they are also members of VHSNC. If these committees are active and they can provide support to CHWs, I think the reach would be much more higher than expected. And then it not only benefits family planning, I foresee it actually benefits the entire primary health care the community. Thank you.
Thank you very much, Dr. Padma, for the insights. And I think your experience actually, mattered a lot here when you discussed about that, what are the challenges which CSW face and how we can strengthen it. And probably like what we see from the data is also that there is a lot of expectations from CSW, but how to build their capacity, how to keep them upgraded with the newer skills, both soft skill as well as hard. That becomes a key to deliver the effective thing. So I think we have a very interesting set of questions. Maybe I'll start with 2-3 questions which are more programmatic because that's how the importance of these discussions are, and then maybe we'll go to the specific questions so far as the technical aspect of this study is concerned. So maybe depending on the time. So we have 10 minutes from now. Maybe Abhishek, if I can pose you a couple of questions which the participants have asked. So one of the important thing is that the issue that though we are saying that the CHW are important pillars, but often we say we have seen from the data that the cultural and societal factors play an important role. And even sometimes CHW find it very difficult to make those entries, especially, for example, the young women, the newly married women. And even if they go and talk about the family planning, often their entries are banned. So how do you see that, on one hand, while we say that the CHWs are important and they are one of the core pillars in the community to deliver the services, but how to address these kind of cultural and societal factors, what can be done? And did you find anything from the data in terms of how they are affecting their interactions as well as uptake? You are on mute, Abhishek.
Okay, so sorry. Thank you so much, Dr. Ravi and Dr. Padma. So we agree that yes, there are so many socio-cultural constraints as well as barrier in the community for CHW to reach, particularly with the newly married women, all those things. But still, our data is showing that even all those barriers, they are making an impact or they are making an effect on reaching those women and influencing the contraceptive use uptake as well as creating the demand for family planning services. So many things I would like to say, which are already discussed by Dr. Padma. So one thing is that we so to answer the first question, like, is there any socio-cultural barrier kind of thing? So like from the broad data at national level, like we see that what is the FLW outreach by different group of caste, religion, education, wealth. Really, we did not see much variation by the coverage of CHW across these subgroups. That is one thing. The second thing is that how we can maximize the use of community health worker among the newly married women or by overcoming the socio-cultural barrier. So one thing definitely we need to train them again and again by conducting refresher training, by hands-on training, all those things to build their capacity or to encourage them to realize that family planning is one of the important aspect or one of the important, or we can say important things to improve the health and well-being of women. So if they are much convinced about that, they can pass the similar message to the community by convincing the community people as well. So what from the field we see, like there is a provision of ASA training on different modules on family planning, but in the practice that does not happen, like not in complete sense, maybe some part of training was given. So ASA definitely needs continuous training, continuous hand holding and reflection training to realize the importance of family planning by their own view so that they can pass the same message to the community. And other than that, we also need to address other factors like definitely incentive part, which Dr. Padma is saying. Like among the CHW presentation or data which we analyze, that is mostly constituted by the ASA. And we all know that they are incentive based. They are working on the based on incentive and they have to do many things and they are not getting the incentives on time or maybe regular. So that is another thing where we need to focus to motivate them to give their best effort on family planning.
Yeah. So a flip side of it is that, again, the expectation from the ASHA. And that's why we have a couple of questions here where the question is that, will the ASHA be the right choice to have these kind of detailed conversations on family planning? Basically for two reasons. One is the amount of work they are engaged with. And the second is that, which qualitative data from UP is saying, is that, those cognitive load, the ASHAs are not able to take, because you have to identify which women has to be suggested with which method and all those things. So probably rather than relying on the ASHA, has to be some other structure like ANM and all. So the question is basically that whether the ASHA becomes the right choice for that, or the focus has to be, or I would not say focus, but the responsibility has to be shifted to the other cadre. And if it is so, then and if we feel that the ASHA is the main person, then there's a question again which talks about that how to keep up their motivation and how to cover those households where we have a lot of unmet need, right? So what are your thoughts around that?
Okay, so I completely agree with your point that ASA are overburdened. They have to do so many things. But I should say, rather than shifting their task on family planning, there should be provision of sharing their task. And for that, we have provision of family planning counselor maybe on the policy, on the programs. But in practice, that is, I mean, you all aware about the situation of UP and Bihar across the country. So if we are able to place the counselor at the facility level, definitely ASA role will be restricted to identify the women from the community. But the rest part of things is who needs what information to be given to which women, what kind of informing about side effects of the methods, its management, and all those things that can be passed on to family planning counselor. This will lessen the burden of ASA. At the same time, I also suggested in previous several meetings, we have been talking about because there is socio-cultural barriers and taboos on talking with husbands about family planning, there should be provision of male health worker kind of thing, particularly for counseling the husband husband on family planning. So since there is no, provision, ASA is not the best choice, but with the given situation, she is the only best person who is doing their best effort. But if there is a provision of family planning counselor and provision of male health worker, definitely that will help a lot to reduce the burden of ASA and again to contribute or maybe on uptake of contraceptive use.
In yeah, thanks. So again, a continued question, which is linked and which I had also noted down to ask, and the same question is being asked by Dr. Tyagarajan, that, we see even in both the states, UP and Bihar, there's a wide range in terms of proportion of women who have been contacted by CHW. Still, the NFHS 4 to 5 shows the improvement, but you have the districts where it is quite low. So what sort of a strategy, one is that we all have been talking that we have to improve the ASHA capacity, etc., etc. But what are the possible, strategy which you think that can potentially improve the, the contact with the women in these two states?
Okay. So yeah, I fully agree that the coverage of CHW or particularly of ASA for family planning is low across the states, though it is increasing. So if we see like imposition of ASA since the NRHM, previously they are more likely to work, or the expectation from them was to work to increase institutional delivery for reducing the maternal mortality as well as improving the health of newborn. But after that, since 2012, after the family planning summits and then coming the MPP program and then FP20, FP2030, then government realized, okay, so now the institutional delivery is going up. So ASA can use those opportunity when they connect with women to inform the women about family planning services. So in that sense, if we are seeing, so from NFHS 4 to NFHS 5, data is clearly showing that there's an increase that is going on, and maybe in NFHS 6 we can see the more increase. But at the same time, given the low level of ASA or community health worker outreach in Bihar and UP, like other than this hand holding, refresher training, all those things, in my experience and my working, some experience working with ASA, I think addressing the monetary issue of ASA will help a lot in increasing the contact with women on family planning. Because that is the main challenge we hear from the ASA mostly when we go to the field, like कि हमारा पैसा टाइम से नहीं मिलता है, हमें रेगुलराइज हो जाना चाहिए, ANM इतना कमाती है, हमारा उसके मामले में कुछ पैसा नहीं है. So these issues should be addressed immediately to increase the coverage. Unless until we address this issue, like focusing on training, refresher training, this will work. But again, that will not give a boost of increase in a field of community health worker on family planning contact.
Yeah, I think that's an important thing. But just to like inform you as well as the audience that the government has well recognized the issue of that, ASHA untimely payment, and I think at least I can say in UP, and I'm sure that similar situation will be in Bihar, that the new like the various digital interventions have been done where ASHA submit their incentive digitally, and those incentives get released in a much quicker manner than what was in the past. So earlier, what we have seen that from the ASHA's, the day she submits to the day she gets the payment, it was almost 2 weeks time, but now it happens within a week's time. So yes, the system level work and system strengthening work is also required. to ensure that they are timely paid and also they keep on motivated. So I think we are at the end of this webinar. We are close to the time. There are a couple of clarifications, like in terms of what was the sample size and what did you include in the when you said that FP discussion, etc. So maybe I'll not go through those questions, because that you can respond to you will have the chat box. But I would like to say that the role of CSW has been seen very important in various MNCH services, not only family planning. While there has been increasing expectations from them, but at the same time the supply side thing has to be also ensured. There was one question on the availability. We see that in both UP and Bihar, the family planning method availability has increased tremendously over the period of 4 or 5 times. So now it becomes that how and in what best way the CSW provides at least initial information to the women and bring it to the facility, or maybe, as you said, to the counselor, so that they can be provided by the appropriate and adequate information and the quality information. So I think this is a very interesting topic, and I would like to thank both Dr. Padma for sharing your experiences, and also enlightening your thoughts around how the CSW can be more empowered, and can be, this cadre can be built with a lot of skills and capacities to handle this complex issue of family planning. And I would also like to thank Abhishek for adhering to the time. That is the most important, but also presenting very informative information from various data sources, and helping us to think through that what more needs to be done in this space. So with that, I would like to thank all of you and close this webinar. Thank you.
Thank you so much, Dr. Ravi. Thank you so much, Dr. Padma, as well.
Thank you.
And thank you all the attendees for being here for at least 1 hour.
Yeah, great. Thank you.
Okay, bye-bye, everyone. Thank you so much.